Hi everyone. I think we'll just wait for a few more people to join this evening for tonight's webinar. I hope you're all comfortable and have a drink or something to eat as we're going to be together for the next hour. Okay, I think we'll get started. So good evening, everyone, and welcome to another webinar by Plant-Based Health Professionals UK. For those of you who haven't met me before, my name is Rahini, and I'm the communications lead at Plant-Based Health Professionals UK and a nutritionist. And tonight, I'm really excited about the webinar and the webinar guest, Dr. Urvi Shah, who's going to be talking about dietary research in cancer and specifically the role of plant-based diets in plasma cell disorders. And she's going to be touching on her own research as well, which is a really exciting topic. And I was lucky enough to meet Urvi a couple of months ago in New York when I was there and connect with her. So really excited to have her speaking to a UK audience of mostly health professionals for the first time. Before we get started, I'd like to thank the British Society of Lifestyle Medicine and the American College of Lifestyle Medicine for kindly providing us with CPD and CME accreditation. You will receive an automated certificate in your inbox within a few days, and also to veganfitness.com for kindly lending us their Zoom platform. For those of you who haven't heard of Plant-Based Health Professionals UK before, we're a community interest group dedicated to promoting the health benefits of a sustainable and healthy whole food plant-based diet. And our members comprise of health professionals, including GPs, dietitians, nurses, nutritionists, and so much more, as well as people who are supportive of our work and want to see plant-based diets in mainstream medicine and healthcare. A last reminder to sign up for the Winchester University Diploma on Plant-Based Nutrition. I think that the next course begins on the 17th of January, if I'm not wrong, and all the details are available online if you visit either our website, and that will take you through to the University of Winchester page. And this course is absolutely incredible, with lots of contributors from our advisory board group and from our membership as well. So hopefully, if you haven't done this already, this is one to really check out, and it's fully CPD accredited as well. And lastly, a reminder to support our work. Do consider joining us as a member. This is open to everyone around the world, or visit pbhp.uk and subscribe to our free weekly newsletter. And if you enjoyed this webinar and want to support us, then the best way to do so is to donate via pbhp.uk/donate. And we're also really active on social media on Facebook, Instagram, and Twitter. Our next webinar, which is about to go up on the website, is on the 15th of February with Dr. Shireen Kassam, who's the founder and director of Plant-Based Health Professionals. And that webinar is going to focus on evidence-based practice in nutrition and what we know so far in 2023. So it's going to explore all the research to date on this topic. But now I'd like to welcome Dr. Urvi Shah to present the evening. So Urvi is going to give her presentation, and then we're going to be joined by Urvi for a Q&A, a live Q&A. So if you've got questions at any point during her presentation, then please pop them in the Q&A box at the bottom of the screen, or if you've got any comments or you want to connect with everyone else, then use the chat as well. So I'll see you back shortly after the presentation. And thanks, Urvi, for taking over.
Thank you so much, Rohini, and thank you all for having me here. I'm really excited to talk to you about this topic that I am quite passionate about. So dietary research in cancer, I think, is lagging a little behind other specialties like endocrinology and cardiovascular disease. Rightly so, because we didn't really have good therapies for cancer patients until recently. So these are my disclosures. So just a little background about myself. I grew up in India and went to medical school there. And through medical school, while we had basic understanding of nutrition, some things, there really wasn't enough information on that. And so we always thought about disease as how do you treat it with different medications. And while there was a lot of patients who might have had malnutrition or obesity, diabetes, and metabolic disorders, there wasn't an emphasis around how we could help guide patients to this. And I'm not alone in what I say with this, because I have heard this from numerous doctors worldwide, that this is an issue not just in India or the UK or the US, but this is an issue worldwide, which is hopefully changing soon. I then did my residency at Tufts Medical Center in Boston and managed internal medicine. So I managed a lot of chronic diseases, cardiovascular disease, diabetes, and chronic kidney disease, and all of this without thinking even once about nutrition through that time, and assumed that the best way to manage it was like, the drugs and the evidence that we had through that. But and then I did my fellowship in New York. So while I was doing my hematology oncology training in New York, this was from 2015 to 18. In 2016, I myself got diagnosed actually with Hodgkin's lymphoma. And that experience of being a patient, cancer survivor now, and going through chemotherapy for 4 months really made me think beyond it, when I had family members telling me, oh, you should eat this or do that. And here I'm saying, I'm a doctor, I kind of know what to do, but really I've never really read the evidence or studied that. And so after I finished my treatment and all of that, I went into reading up about this just more out of interest, and realized there's a whole body of literature that we don't really study in our fellowship program or training, and that most oncologists don't know about it. But there is information that really should be shared and thought about. And then I did an advanced fellowship in and during that time at Montefiore, I also did some research, but in a type of cancer called adult T-cell leukemia and lymphoma, a lot of genomics and other things, not looking at nutrition. The nutrition part was a hobby of mine that I would read about, and I slowly adapted my diet to become more whole food, plant-based, and improve on things that I didn't, think about before. And then when I moved to MSK in New York for an advanced immunotherapy fellowship, I switched from doing more lymphoma research to myeloma research, given some of my mentors were working on the latest CAR T-cell therapies for myeloma, and I thought that my focus would be immunotherapy going forward. However, when I joined as faculty on the myeloma service, I had always this passion and desire to do one of these like nutrition intervention studies. And so I worked to design that during my early faculty position. And since then, one thing led to the next, and I have pretty much focused now only on dietary and lifestyle interventions and other modifiable factors for cancer, mainly plasma cell disorders. So because that's my focus area of plasma cell disorders, and I will be mentioning these words throughout my talk, I just wanted to mention very quickly what they mean so that you're not confused when I mention these words. So MGUS and smoldering myeloma are the precursor disorders, and usually the standard of care is observation for these patients. So patients can have an abnormal protein in their blood. Often this is diagnosed just because they had the blood test done for something else and then it was found. But the patients are often very anxious because they're told there's nothing that you can do, but there is a risk that you will progress to cancer. And then multiple myeloma is the blood cancer that many of you must have heard of, but it is considered incurable for the most part, which means that patients are on chemotherapy almost lifelong when they have this. There are a few exceptions where patients may be cured now. But what's interesting with this disorder is when I was in medical school, we thought that there really wasn't much. The overall survival was like, less than a year or somewhat in that range. And just if you look at the improvements in the number of therapies approved for this disorder over the years, you can see that we have so many, and this is a moving target, which I think is going to continue to improve, and potentially we may be curing more patients. So there definitely is an opportunity to improve outcomes further with dietary and lifestyle interventions. And I think this is the same for all cancers across all specialties at this time. This is an extreme but not uncommon example of a list of comorbidities from a patient of mine. And you can see that this patient has multiple issues, but within all of this, they also have multiple myeloma, and where we have to try to treat them with chemotherapy and manage all these chronic issues as well simultaneously. So that makes it much harder to do because, of the side effects. And because of this, the patient was not a candidate for stem cell transplantation, CAR T-cell therapy, clinical trials, or even intensive chemotherapy, and so had a decreased overall survival. What I've highlighted in green are things that I think if the patient had a healthy lifestyle over their lifespan could have potentially been avoided and improved their likelihood to get some of these therapies. So even if we think that diet doesn't directly impact cancer, it definitely indirectly impacts it through the ability to give them the treatments we need. This is shifting gears to colorectal cancer, but I really like this study because this is a study from the UK Biobank. And what they looked at was patients with colorectal cancer and calculated something called a polygenic risk score. So a polygenic risk score means it's telling you whether the patient is low, intermediate, or high risk in terms of their genetic profile to develop colorectal cancer in their lifetime. Then they also calculated a healthy lifestyle score based on body fat, physical activity, diet, alcohol, and smoking, and divided patients into healthy, intermediate, and unhealthy. What you can see here is the patients who had the bad genes, so the high genetic risk score and a bad lifestyle, had the highest risk of developing colorectal cancer. And if they had a really good lifestyle despite bad genes, their risk was similar to the intermediate risk category. And so while genes may not be modifiable, lifestyle is. And I think that, this just goes to show how we can potentially affect odds. Additionally, with my cancer patients living longer, infections is a big issue and risk with the newer therapies that we have. And with COVID, all of you as oncologists or people who treat cancer know about this. And there have been 2 studies, actually probably more, but I wanted to show you 2 that looked at diet and COVID severity. And this was also a patient from a study from the UK with more than 500,000 participants. And what they showed is those who had a higher plant-based diets, meaning more plant-based foods in their diet, had a lower risk and severity of COVID-19. And if one study is not enough, this was a study actually in healthcare workers from 6 countries. And what they again showed is those who were eating more plant-based diets had lower odds of moderate to severe COVID, 73% lower. So diet may affect also how patients do with COVID. And while we must, think about all the other aspects of treating COVID, I think diet can be a powerful tool to at least reduce the risk of severity. So thinking about nutrition, I think good nutrition is important for cancer at all stages. In the prevention setting, we're thinking about dietary therapies as a backbone, as I showed you with the colorectal cancer data, where we can reduce the risk. We may not, completely eliminate cancer, but we can certainly reduce the number of patients who develop cancer and also other medical problems. And this could also be prevention once they develop cancer for secondary cancers. And the AICR guidelines say that AICR talks about how 1/3 of the most common cancers could be prevented through diet, physical activity, and weight. In terms of the treatment setting, while historically cancer treatments used to be very hard for patients to tolerate, nausea, vomiting, poor appetite. So trying to tell a patient at that time, like, oh, you need to eat better or think about these things, was really futile. And that's where I think most oncologists are in the thinking of, like, it doesn't matter what a patient eats. But I think now with the advent of newer therapies like immune therapies, but also patients doing much better, we have so many drugs for nausea management and things, patients are actually tolerating therapies better. And so there may be an opportunity to think about synergy between diet and chemotherapy as well. And then in the survivorship setting, thinking about it in combination with maintenance therapy or decreasing the likelihood of relapse once in remission, or reducing the risk of other cancers and medical problems. And so dietary interventions as secondary prevention, as an oncologist, we have the opportunity. Now, this is, blood cancers, but I think the same applies for DCIS or other cancers where, we can intervene possibly to reduce the odds of progression or conversion for patients. And unless we, as the medical professionals, talk to patients about this, patients are not going to believe that it's possible or think that they need to do anything. In terms of the treatment side of things, could using diet with the drugs and the standard of care improve outcomes further, like MRD negativity, progression-free survival, overall survival, or quality of life? And then in the survivorship setting, some cancers require maintenance and some don't. But could diet and lifestyle actually improve the likelihood of time to first relapse or even survival if it's a cure for some? So what food or supplements can I take? And I think all of you as practitioners would have been asked this question at some point in your practice. And I think it's kind of one of the most likely questions to be asked by patients, and also the least likely question to be answered by us as oncologists. And so there is a unmet need for dietary research in heme malignancies and to bring it a little bit more mainstream. And so when we talk about plasma cell disorders, we surveyed about 400 plus patients through the Health Tree Foundation, and we asked them questions around diet and their habits around this, and asked, since your diagnosis, did you have questions around this? 82% said yes. 57% said their oncologist didn't address it. And 94% said that if their oncologist gave recommendations, they attempted to follow them. So patients do try to make changes if we do suggest things. And patients on their own reported an increase in fruit, vegetable, whole grain, plant protein, and seafood consumption, and a decrease in red meat and junk food. While this is self-reported and there may be some bias with that, patients are making changes on their own, whether we like it or not. So it would be nice if we could give them some guidance with that. These are the AICR guidelines, and only a third of the patients that we surveyed actually even knew about them. So despite there being, guidelines with so much robust data, very few patients even are aware of them. And the AICR website is a really good place to look at foods that fight cancer, which are pretty much all plant-based foods, and foods to limit here, which are sugary foods and red and processed meats. So some of the things I'll focus on in the next section will be like, how do we think about nutrition in the sense of obesity, diabetes, general diet, and the microbiome. And I'll go over a few studies in each section. So when we think about obesity, actually there are 13 cancers very clearly associated with having an elevated BMI, and multiple myeloma is one of them, but there are 13 different ones. And the obesity incidence, these are numbers from the US, but I'm sure it's close even in the UK, maybe not as much, but the obesity incidence is just rising, and more than 70% of the population is overweight and obese. So normal is not normal anymore. And when we think about obesity, it increases. So here I'm just discussing the plasma cell disorders, but if you think about MGUS, which is the precursor disorder, obesity increases the risk of that, but it also doubles the risk of progression from the precursor disorder to developing myeloma. And also extreme BMIs are associated with increased risk of death or myeloma as well. So there are different mechanisms by which obesity may affect myeloma, but all cancers. Through the increase in the adipose tissue in the bone marrow, changes in adiponectin, leptin, resistance, inflammation, the insulin IGF axis, estrogen, other hormones. And so while it's important to think about this, it's also important, patients who are unintentionally losing weight or who have lost weight during treatment need to be also monitored the other ways. So I'm not saying that, everyone needs to lose weight, but we also have to think about the ones who've lost weight because they could potentially do worse as well. So we looked at in myeloma outcomes with extreme BMI, and what we saw was that severe obese or extreme, like being underweight, were both associated with an increased, a reduced progression-free and overall survival. While the association was stronger for being underweight, the severe obese, while not significant, there was a trend towards that. And extreme obesity was more of significance than just being obese. The next part would be talking about diabetes and how does diabetes increase risk of cancer, and does it really? In the US, we have almost 40% pre-diabetic or diabetic, actually 45%, but it's sometimes, it's hard to tease out correlation from causation. And there are a lot of factors that go into it, but correlation would mean that whatever the risk factors are, genes, diet, age, weight, lead to diabetes and lead to cancer. And you just see both of them in the same people because the same factors are causing them both. Or we think about causation as these factors are causing diabetes, and then the high blood sugar and the high insulin is what's driving the cancer. And I think it's probably somewhere in between where it's both these things combined. But there have been numerous studies looking at both blood cancers and also looking at overall cancer risk. And there is an association with numerous different cancers. Some of the association is time dependent, meaning that the risk is highest soon after a diabetes diagnosis than further out. And that could be because of uncontrolled insulin and sugars at that time compared to when metformin kicks in, which may have anti-cancer effects, but it's not clear because we don't really have too much data around that. And there was a recent paper, which I haven't shown you here, but published in JAMA Oncology, looking at insulin levels and insulin dose in type 1 diabetics, showing how insulin dose is associated with cancer risk. The next part I wanted to talk about was nutrition and diet. So we'll go over different dietary components and overall patterns. And so these are three, when we think about diet and cancer, a lot of the research that has happened so far has been looking at large population studies. And while as, healthcare providers and oncologists, we're skeptical about epidemiologic data, I think if you're seeing the same pattern across multiple populations and multiple studies, then I think, that does solidify the evidence a little more. And so you can see here, this is data from France, from the US and UK, all showing that plant-based diets were associated with lower risk of cancer. They studied it in different ways, either with a score or looking at vegans, vegetarians, meat eaters, fish eaters. We see the same thing in myeloma, where there's not as much data, but because myeloma is rarer, but this study showed that patients who eat healthier plant-based dietary patterns, like all of these patterns are, pretty much plant-based, had 15 to 24% lower myeloma deaths and overall deaths. And those with a Western diet and inflammatory patterns had higher myeloma deaths. And in the EPIC Oxford study, if you just look at the table or the subgroup, they have looked at myeloma as well and showed how vegans and vegetarians had a 77% less relative risk reduction in myeloma compared to meat eaters. So there is some epidemiologic data here suggesting again that plant-based diets would be associated with less cancer overall. Fruits and vegetables is also looked at, for cancer, and there's the prospective study. So this was a systematic review and meta-analysis that showed eating about 7.5 cups per day or 7.5 servings was associated with a 14% reduction in total cancer risk. And the USDA does recommend about 5 to 9 servings per day. With whole grains and cancer, very similar story, where more whole grains are associated with less cancer overall, but less also colorectal cancer and decreased cancer-specific mortality. Whole grains are more than just fiber, and I think this is very important because in a world where people fear carbs and think that carbs are bad, we can't throw the baby out with a bathwater kind of thing, where the whole grains are not the bad part, it's the refined grains. And so all carbs are not bad. It's like, thinking about what carb are you talking about. And so their recommendations are about 3 servings per day of whole grains. And whole grains have more than just fiber. There's zinc, antioxidants, vitamins, phytoestrogens, and minerals. I wanted to talk about 2 studies looking at fiber. This one I thought is really interesting. It's from a few years ago, but what they did is just a 2-week diet switch in healthy middle-aged adults. They took 20 African Americans and 20 rural Africans from Africa. What they did is they asked them to switch diets. So they made the African Americans eat the rural African diet and the rural Africans eat the African American diet. And these were healthy individuals, so they didn't have cancer, but what they did is they biopsied the colon mucosa before and after. So they did colonoscopies on these patients. What they showed was that the proliferative index, so Ki67, decreased in 2 weeks, as you can see with the brown staining, that's much lower here, and increased in 2 weeks just by changing diet pattern. So the Americans that ate the African diet actually had a reduction in their Ki67 and vice versa. And they saw also changes similarly in the inflammation and lymphocytes and macrophages. They also looked at butyrate producers and showed that the native Africans, once they switched to a Western diet, actually had a reduction in butyrate producers and the opposite in the African Americans. So very quickly in 2 weeks, you can already start seeing changes. This is a study from melanoma, not myeloma. So this is a skin cancer, but I find it also very interesting because they looked at dietary fiber and probiotics. So this was 128 patients with melanoma and immune checkpoint blockers, so immunotherapy. And they didn't give them a diet, but they just asked them to fill out, information on what they eat, and looked at those who had high dietary fiber, and also asked them if they take probiotics or not. Those who ate high dietary fiber but no probiotics had the best progression-free survival. Those who had a high dietary fiber with probiotics actually had a worse survival, similar to those with low dietary fiber. And this is interesting because in this era where we also think that maybe probiotics is good for everyone, we need to be thinking about it in the context of therapies. And while we don't know exactly why this may be, I think it could be that a probiotic might be reducing the diversity of the microbiome and changing it in a way that's not helping the immune therapy. Next thing we can talk about is red and processed meats. And so I'm sure many of you are aware of this paper that was published in Lancet in 2015, where the IARC, scientists convened and they reviewed more than 800 studies and then talked about how there's the largest body of evidence for data on colorectal cancer and also some on pancreas and prostate cancer and cancer of the stomach. And with that, after this paper, I think is when processed meats have been given the category of a group 1 carcinogen, and red meats group 2A, meaning probable, and group 1 means definite. So what are the mechanisms by which meat may be linked to cancer? And while there are many different ways, I don't think we can point to just one thing and say that's what's driving it, but I think there are many different ways that it could be. This study, again, very interesting, but they tried to show the mechanism in colorectal cancer. What they did is they took the whole exome sequencing data from 900 colorectal cancer patients, and they looked for an alkylating mutational signature in the sequencing data. Then they looked to see the amount of red meat, chicken and fish intake, whether it was high or low, and high intake of red meat. So this bar was significantly associated with the alkylating signature, and the alkylating so higher red meat or processed and unprocessed red meat had higher alkylating signature contribution in these colorectal cancer cases. So they said that they are showing the mechanism of how red meat is affecting the alkylating signature in the genes and leading to colorectal cancer development, and showed that those who had the highest alkylating signature, that's Q4, actually had the worst survival too with colorectal cancer. Next thing I wanted to just talk about was dairy. And I think the data here is a bit more limited, but I would urge you all to read this paper if you haven't in the New England Journal about milk and health. So it's looking at it all overall. And what they do talk about is milk consumption correlates with cancer incidence in different countries. But of course, this is not causation, and this doesn't mean that, yeah, more dairy is definitely associated, but they do show that these causations are all related to like hormonally driven cancers. And there is a study that looked at, prostate, ovarian, endometrial, and breast cancer, so the hormonally driven, and looked to see whether, this was looking at different, so each circle is like one different study. So as you see, it expands. Like here, you're seeing 5 different studies, and the red lines mean increased risk, green means decreased risk, and black means there's no association. So while the risk may not be so clear with ovarian, breast, and endometrial, it's more clearly dairy has been associated with prostate cancer, because probably it is through the IGF-1 and hormonally driven mechanisms is what's thought and suggested. IGF-1 may be one of those links, and the mean serum IGF-1 concentration was looked at in this study, and what they showed is that patients who eat low dairy intake actually have lower IGF-1 levels than those who have a higher dairy intake. So vegans had 13% lower IGF-1 than meat eaters and vegetarians. And elevated IGF-1 levels increase cancer risk by 15% in this study. So just summarizing all of this, we published a paper recently looking at 2 common diets that are really talked about in oncology and cancer, and looking at how they may affect cancer reduction or risk through the different mechanisms. And I think, plant-based diets increase fiber, reduce transit time, improve short-chain fatty acids in the stool, and insulin-like growth factor and inflammation reduction. All of these are different mechanisms that it could work with. Whereas ketogenic diets, while they have many similar mechanisms to a plant-based diet, which are all in purple, the different mechanism is the beta hydroxybutyrate or the ketone bodies. I would think of the ketone bodies as something, similar to the butyrate in its mechanisms, where it has anti-cancer and anti-inflammatory effects too. But remember that when people actually say they're doing ketogenic diets, they're often on low carb diets, because to stay in a state of sustained ketosis for long periods of time is not often sustainable. So often the people who are doing ketogenic diets are actually doing low carb and only getting these effects and not the ketone body effects. And while there is more data around the plant-based diets, we're seeing, the field in oncology doing more ketogenic diet trials, which is surprising. But we have on clinicaltrials.gov, there were 46 keto trials and only 8 plant-based trials, despite the evidence in epidemiologic studies being to the contrary. The last part I wanted to talk about was the gut microbiome in health and disease. And it's important to remember we are more microbiome than human genes. So, if we think about how many genes are there in us, we're more microbiome than human. And we're just scratching the surface, I think, of the microbiome at this point. And it's probably the next frontier in oncology and medicine that's being looked at. We had genomics, we have immunotherapy, and the next, I think, is microbiome coming. But with that, you see that there is a lot of different things that the microbiome can affect, because it's so powerful as a modulator of different factors. And the biggest driver of the microbiome is usually diet. So this is now, a few studies in myeloma and the microbiome, but I think they're interesting, where this is in a mouse model. They gave these mice antibiotics to basically kill off the microbiome that they originally had, and then did a fecal microbiota transplant, meaning gave them stool from a myeloma patient or a healthy control, or gave them just saline. And then they showed that over time, the mice that actually got the stool from a myeloma patient had the myeloma progress the fastest in the mice compared to if they got the stool from a healthy control with nothing else changing. So the microbiome can accelerate or drive tumor progression in this mouse model, suggesting that the microbiome may be an important driver. Here they also show how a different bacteria does the same thing. A good bacteria reduces the risk, a bad bacteria increases it. Similar with that data, this is a study we recently did where, in myeloma patients, after they finish their initial chemotherapy, they go on maintenance therapy with lenalidomide. So we collected diet and stool samples from these patients, and then we correlated diet with the microbiome and with outcomes. And what we show is that having more diversity in the stool, having more butyrate producers and more butyrate levels was associated with higher likelihood of sustained MRD negativity, means higher likelihood of staying in remission. And what you can also see is that we looked at different dietary factors and flavonoids, which are seen in plant chemicals, and they were associated significantly with the butyrate levels in the stool, suggesting that dietary patterns may be affecting the microbiome and through different mechanisms affecting long-term myeloma control. So this is a way that we're not just having myeloma improve survival through other diet improving survival through other comorbidities, but directly through control of the disease. And this is a study not in cancer, in healthy population, showing how a plant-based diet can improve butyrate levels just with 5 days on the diet. So you can see that diet can very rapidly change the microbiome, but obviously the diet needs to be sustained if you want those changes to continue in the microbiome. This is another study looking at plant foods and how many do you eat per week, and they show how more than 30 plant foods are associated with improved diversity of the stool and gut microbiome. And there are a lot of studies, which I'm not showing you here in the interest of time, that higher diversity in the stool is associated with improved survival in myeloma and other cancers. So some of our research was thinking about, like, we know all these factors are affecting myeloma development, and how do we tilt the scale to reduce the risk of development of myeloma through a study where we're doing an intervention like a diet and look at biomarkers of progression. So this was our pilot study where we did 12 weeks of a whole food plant-based diet with nutrition coaching for 24 weeks provided through Plantable, and we followed the patients for 52 weeks. We actually shipped them lunch and dinner and provided them counseling for the rest of their meals. And people were eating to satiety, no calorie restriction, so they could eat as much as they wanted. And what we saw was, we had a nice enrollment of different patient population, but we saw very good adherence to the diet. Their baseline unprocessed plant food intake was 19% before they started the study, and it went up to 91% during the 12 weeks on the study. So the preliminary results so far do show that it is feasible with the adherence. And here is the weight loss data too, showing that there was a median 8% reduction in BMI at 12 weeks. And this was all patients with a BMI over 25. So we were looking at weight loss as a marker. There was improvement in insulin resistance, insulin, IGF-1, CRP, so inflammation. And here you can also see changes in the adiponectin-leptin ratio, relative abundance of butyrate producers, and stool butyrate concentrations. So tying it back to what I showed you previously, how higher butyrate levels can be beneficial potentially, we are able to modulate the microbiome through diet and improve these butyrate levels in patients with precursor disorders. So based on that pilot study, we are now doing a larger study in patients, and this study is currently enrolling patients with MGUS or smoldering myeloma are randomized to either get diet or supplement, which is omega-3 and curcumin, because not all patients want to change their diet, and we want to see what the effect of these supplements are without dietary changes compared to placebo supplements. And then those who get the supplements eventually get the diet as well to see the combined effects. Another study we are doing, so those studies that I talked about were in the precursor setting, so trying to reduce the risk to develop myeloma. This is a study in the survivorship setting after myeloma has developed and once they are on their maintenance therapy. So we had a quality of life study looking at 2 different drugs. And what we're doing is a subgroup of these patients, 15 in each arm, could get the diet, the plant-based diet, and we're going to look at the effects on the microbiome and also long-term remissions. So just to summarize a few things, when I talk about plant-based diets in this thing, often people ask me, like, what do you mean by that? And like, how do you think about it? So I think about, a vegan diet is a diet with 0 animal products. It's usually, when we think about the ethics behind animal agriculture, global warming, and all of these things. And most people who are vegan are driven by these fundamental values. But it doesn't have to be healthy. With a lot of the processed meats, plant-based foods coming in, you can be a junk food vegan as well. Vegetarian, these are also with only some animal products like dairy and eggs. But again, it's often ethical and religious reasons why people are doing this for a long time. But again, it doesn't have to be healthy because you can be eating a lot of fried foods or, cheeses and things like that. And then when we think about a whole food plant-based diet, this would be either minimal to no animal products, but it's focused around a healthful plate. So there's a lot of focus on unprocessed foods and mainly plants that would be a healthy diet. So one, big stark area that we could work on is the fiber gap, where 67% of people in the US, and I think this will be similar in most countries, believe that they meet their fiber needs, but in reality, only 5% of the population gets their fiber. So I really think, when people are obsessed about protein, they really need to be obsessed about fiber, because we are living in fiber deficiency, not protein deficiency in the country. I don't think, we really see anybody with protein deficiency. So when I think about, what you want to be, and this may be vegan, vegetarian, pescatarian, Mediterranean, low carb, keto, I think all of these could be potentially done with a 90% or 80% of your plate coming from a whole food plant-based diet. And the Canadian food plate is a nice example of that, where half the plate is fruit and vegetables, a quarter is whole grains, a quarter is plant protein, but it's mostly plant-based protein. And if you just think about how much is the meat, it may be less than like 15%. So another reason why plant-based diets are associated with good metabolic profiles is because the concept of calorie density. So when you eat 500 calories of a plant-based food, it's high in fiber, and so you may get full quickly. So that is the reason we saw even weight loss in our patients with eating enough to satiety. And if you eat 500 calories of really energy dense foods like cheese or oil, you're not going to be full, and you're still going to want to eat more. So you automatically just end up eating more calories. And so with that, I just want to conclude that, we have metabolic disorders like obesity very strongly linked to cancer. Diabetes also maybe less strongly, but quite clearly linked to cancer. Nutrition is important in many different ways in the prevention, treatment, and survivorship setting. I think we're just scratching the surface in terms of interventional trials across the world, but as we see more of that, hopefully more oncologists and doctors will buy into this idea and believe it, as well as hospitals bringing in clear ways to support patients. And I think, like I said before, the microbiome has brought diet to the forefront as well. As we think about how the microbiome is such an important player, the diet can no longer be ignored. And so as we think about how do we shed light on understanding dietary mechanisms better, thinking about how diet in terms of patterns, foods, or supplements are affecting the microbiome, metabolism, the immune system, and the outcomes. And so how can we flip the switch to start thinking about these things and make everybody aware? So with that, I'd like to really thank all my collaborators, colleagues, mentors who I work with. I think doing this kind of research does take a village, and it really wouldn't be possible without the funding and the support of my team. So thank you, and happy to take questions.
That was incredible. Thank you so much, Urvi. I learned a huge amount, and I love that you summarized so beautifully your thoughts on, the dietary approach that you think is most optimal, which I'm sure most of us who are on this call would agree with. I think we've got a few questions, and I think probably some more will come into the Q&A. One of the questions was that came in is, which I'm sure a lot of health professionals who are listening always have this sort of question. How did your colleagues react to this, and were they supportive of all of this work? And generally, what has the response been amongst other health professionals that you've come across?
Great question. I think, sometimes to make the changes on the inside, you start needing to make the changes outside. And then when people start hearing about it, they realize the importance of it. And so I think with dietary changes and all of that, like, while I've had very supportive colleagues, and everybody, where I work and even in oncology, look at it and have nothing but good things to say overall, I think for them to bring it into their clinical practice or start talking about it with patients, they need more data, or they're not yet convinced. They think like, okay, what you're doing is good, but that's something, in the research world or on the side. But to bring it to the forefront or get doctors to start believing in it, I think we need more of, like, as patients also show enthusiasm for these things, bring in more evidence, doctors are starting to listen. So I have seen a clear shift in the last few years where doctors are starting to believe it more than, and I feel like that they're getting more convinced over time.
That's incredibly positive. And obviously you're based in New York City, where the plant-based by default program has now been rolled out. Is your hospital one of those that's going to adopt that? And has that already happened, or is it in the pipeline? For those of you who aren't aware, this was basically new legislation that was passed, that in New York City, if I'm not wrong, that plant-based menu would be the default in hospitals and things. But I'm not sure to what extent that's already been put into practice.
Yeah, so the American College of Lifestyle Medicine, and I think Eric Adams, the mayor of New York, have put together this whole training program for all medical professionals in the New York State area, or New York City, I think. And I think it was just announced a few months ago, so I think it's going to be rolling out soon. I know MSK is part of that initiative, though I haven't seen it yet happen, but I'm excited to see that we're going to have training for all doctors through that. Also recently, just actually earlier this week, I saw signs in the cafeteria at MSK saying plant-centric, and they were starting to label things around that. So I think that's also a way that, like, now, before it used to always be like, if you're trying to do this, it's difficult because there are barriers of where do you find the food. Not the cafeteria is unconducive to this, but I think it's changing. And I think we're going to see that in most hospitals now.
That's so positive. And what about the feedback? You talked about how your colleagues responded, what the hospital's doing. How about the actual participants? What was their feedback about the dietary change? And what were the comments that came up?
Yeah, that's a great question.
Did they plan to stick with it as well, after the study period was over?
Yeah. So I think the trial has been literally life-changing for some of the patients. Of course, with even drugs and everything, it's not going to be 100% because not everybody is going to stick to it or follow it. But I could say that the ones that have actually done it and taken it to heart and done it seriously, it's been nothing short of life-changing for them. And they keep bringing it up and talk about how grateful they are to be able to have been a part of this study. So for instance, we had one patient, just an example, who was diabetic on insulin for more than 30 years or something, and used to have a continuous glucose monitor and all of this, and then went on the study and also had chronic kidney disease, I think stage 4 or 5, and went on the study. And it's been more than a year since he's off the study, but still continues to follow the diet to this day, has stopped insulin since about a month or 2 on the study, never been on, like, doesn't need diabetic medications anymore, and feels like he's never been at this weight since he was in his 20s. So, and he's in his 70s now. So he feels like he's had a new lease of life in terms of what this has done for him. Also, like there's data on how plant-based diets help with chronic kidney disease, and the National Kidney Foundation actually has a whole section on plant-based diets for kidney disease as well. So with that, it seems like his kidney disease has also plateaued, and maybe it delayed like him going on dialysis.
No, that's such an incredible example, and there's some lovely comments that are coming in. Hopefully I'll save them and be able to share them with you, but
that would be great.
Thank you for bringing this research front and center. Look forward to immunologists and integrating nutrition into their studies in patient care. Very informative. That great presentation, so passionate. Just really lovely comments, and I can see that everyone who's joined is really engaged with this topic as well. One of the things that you mentioned was, one of the things that I also got a question about was about bone health, which is an issue with patients with myeloma. So does there need to be more of an emphasis, even within a plant-based diet, on foods that are rich in calcium and vitamin D, as we know those are kind of team players when it comes to bone health?
Great question, and I don't think we have clear answers on that, but a few things I would mention is that, calcium and vitamin D are not the only things we need for bone health. You need good overall nutrition, protein, vitamin K, other minerals, and things like that too, and as well as resistance training or exercise. So there have been studies looking at that, if you eat a plant-based diet and do the exercise or do the resistance training, your bone health can be as good as, or you can reduce your risk of fractures with that. So I think it's not just about what you eat, but also how active you are. And I think we live in a world where most people are very sedentary. And I think with myeloma, what ends up happening is a lot of patients, because they've had fractures and things like that, they often end up being pretty sedentary. So trying to get them active, doing very slow, small changes would also helping with bone density. And then, of course, the things that we would do, the calcium, the vitamin D, and things like that. And there are enough plant-based foods that are high in calcium and calcium rich too, that could help with strengthening the bones. So it's not so much about, a lot of data goes into like, oh, vegan or vegetarian or who has best bone health. But I think it's more about the nutritional quality than the name that we give to the diet. So whether it's a whole food plant-based with a lot of healthy grains and protein and things like that, versus doing a Western, a non-vegetarian or a Western or a fish eater or a vegan, but it's like not got the whole nutritional profile that's there. So that's the main thing that needs to be focused on.
Definitely that diversity of plants, the different, the variety, the colorful fruit and veg, and all of those components. And there's a question here, which is from someone who says that they're struggling with fiber intake. What would 30 grams of fiber look like over the course of a day? So in the UK, the RDA is 30 grams, and only 1 in 10 gets it. So slightly better than the US, but not much of a margin. And certainly on a whole food plant-based diet, you can be getting 60 grams, 70 grams, upwards of that. With regards to that, I would say please check out the Plant-Based Health Professionals UK website, because we have an Eat Well guide, we have recipes, we have a 21-day plant-based challenge, and that's going to help you just visualize and understand, where that could come from. But again, I totally echo what you say, Urvi, for this kind of thing, that it's getting in a diversity of plants. But to get 30 grams isn't too difficult. A cup of chickpeas has about 16 grams of fiber. A cup of oats has about 8 grams of fiber. A handful of nuts will give you 4 grams. So you're very quickly just adding that all together will give you 30 grams of fiber. That's not including hopefully the fruit, maybe some flax, maybe some other whole grains like brown rice. You can easily hit 30 grams and way more. So don't worry about that. If that feels overwhelming, just focus on adding in a bit more whole grains, fruit and veg and beans for now.
That's so true. Just to add, it's like, I think if you just focus on the eating healthy, unprocessed plant foods, you don't even need to count the fiber because you will exceed and meet it really well. The issue is that most people eat white bread and refined rice and white rice and things like that. So while they are grains, they are not getting the fiber part. Like the whole grain is the important thing, the fruits, the vegetables, the beans, a lot of fiber and all of those things.
Totally. One of the other questions is, do you have a hypothesis about which therapies in myeloma might benefit the most from a whole food plant-based diet? There are so many treatments, but which one do you think will benefit the most?
Good question. I think, this is going to be something, the short answer, I think, is like every therapy would benefit, because I think, it's whether it directly benefits or indirectly benefits. But I think that, for instance, in myeloma, lenalidomide, as I showed some data, is a drug that, often patients have side effects like diarrhea, but the diarrhea is supposed to be associated with eating more fatty foods and things like that. So just automatically going to a plant-based diet may improve like some of these side effects that patients are feeling. Or, carfilzomib is associated with cardiovascular side effects, but we know that plant-based diets are associated with reduced cardiovascular risk. And so could some of these things just automatically reduce? And then I think now with the new immunotherapies, I think there's going to be a lot of interaction of how the immune system through diet, because diet very clearly affects the immune system through the microbiome, or even alone, as we see with less COVID and things like that, it's through the immune system. That could it be that there's a synergy of these immune therapies and diet to help the immune system fight these cancers? So I think we'll see more on that too.
Fascinating. I'm just going to launch a quick poll to get everyone's feedback. There is one last question that's come up, which is, what's the role of the health of mitochondria in cancer?
What's the role of the mitochondria?
Health of the health of mitochondria in cancer.
I don't know that I have an answer for that. I think we want the health of, it's important that everything, all our organ systems and even the mitochondria and everything in our body is functioning well. So overall, I would think it's important, but I don't know enough about that.
Yeah, at that granular level. There are so many lovely comments, and I just want to thank everyone for sharing those. There's one last thing that I did miss, which was someone who's said, thank you for the presentation. Pro and prebiotics are a recognized treatment for melanoma patients on immunotherapy. I didn't catch the paper, but are you suggesting from this that this is not the right way to go for these patients?
Yeah, that paper is in Science and published from the MD Anderson group. It's a melanoma with immune checkpoint inhibitors. And what they showed is actually probiotics reduce progression-free survival. Obviously, it's not an interventional study. It is retrospective, but higher dietary fiber improves progression-free survival. High dietary fiber with probiotics is not as good and reduces progression-free survival. And like I said, I think it is based on reducing diversity. When you use probiotics, you're enriching for 6 or 7 species of the bugs in that probiotic, and you might be reducing the other hundreds of bacteria that are already there. So when you eat different plant foods or different foods, you're getting different bugs activated, and different bugs in the feeding the microbiome, like different foods feed different bugs. And so you have more of a diversity, and trying to have a highly diverse microbiome is associated with better outcomes across many cancers.
Yeah, and many other chronic health conditions as well. Yeah, I totally agree with that. And there's the diversity of both prebiotics, probiotics that you can best get from the array of whole plant foods. Yeah, fantastic. Thank you so much, Urvi, for joining us. I know it's bang in the middle of your work day over here in the UK. It's sort of evening time, but we're very grateful for you to carve out time in your diary to give this presentation. It's been absolutely fascinating, and the research that you're doing is groundbreaking to say the least, and is definitely going to change so many lives and will continue to do so. So thank you so much for everything and for the great Q&A as well. And thank you to everyone who joined. We had a great turnout this evening. And for those of you who want to watch this recording, it will be up in due course on the members page. So for anyone who's not a member of PBHP, if you want to join us as a member, you can access this as well as over 60 other webinar recordings that we've had in the past, and you can still claim CPD for that as well. So join us on the 15th of February with Dr. Shireen Kassam talking about evidence-based nutrition practice. And it's a really important topic for everyone, not just nutritionists and dietitians in the group, but absolutely everyone to learn from. So hopefully see you then. Thank you and good night.
Thank you so much for coming.